Welcome back, everybody, to the second chapter, Understanding Intravascular Lithotripsy and Where Does It Fit into Our Practice. So we all know the lithotripsy technology has been safely used for the last 30 years and more in the kidney stone treatment. And what Shockwave did was incorporate this lithotripsy technology into a PTA platform, and it uses this as its delivery mechanism. As it's a PTA platform, it's a very easy tool for every interventionalist out there. So it's a simple setup, including a compact and rechargeable generator. Then you have the connector cable and the IVL catheter, where you have inside of the integrated PTA balloon lithotripsy emitters. So how does it actually work? Well, it's quite easy. You position your IVL catheter at the level of the target calcified lesion. You then inflate it very low pressure of only 4 atmospheres to obtain vessel wall apposition of the balloon, and then you start your energy delivery. And what happens is that there's going to be an electrical discharge from the emitters, vaporizing the fluid in the balloons, creating a rapidly expanding and collapsing vapor bubble, which then generates a sonic pressure wave. This sonic pressure wave goes into the vessel wall, creating microfractures within the superficial and deep calcium, changing vessel compliance and facilitating controlled vessel expansion without causing any trauma to the soft tissue. So to summarize, it's an O14 platform where we deliver our catheter to the target lesion, we give out our energy, crack the calcium, and then safely expand the vessel. And as you can see on the 2 images below from the micro-CT, pre and post IVL treatment, we see these transverse and longitudinal microfractures which change our vessel compliance. So previously we had the M5 IVL catheter to facilitate our access for our endografts. And recently Shockwave introduced the M5 Plus catheter, which has a bigger size of 8 millimeter. And this will help improve complex access situations, not only with the longer shaft, which then caters us for an upper extremity approach, to prep the iliacs if transfemoral access is not an option. It's also the largest size, so we can more optimally treat larger diameter vessels. And it's 50% faster, so it's even more efficient. So what about data? And Shockwave came up with a lot of data in a short amount of time. And what we see from those data, especially in the randomized controlled trial, or even in large observational studies, is that at the final of the procedure, we see very low residual stenosis. And what is very important is that it's happening in a very safe manner. And from this large observational study, we also learned that this effect occurs in all vessel beds. And what is interesting for us, of course, when we're talking about delivering our endograft and access is, of course, the iliacs. And also here you can see it's a very safe technology where it's also almost 0% perforation, no distal embolization. So this is what's very interesting for us. And there are some very small amount of data where they were using it for large bore access. And what is the key takeaway message in what we see in these trials was that the stenting rate was actually quite low in the iliac bed of only 41%. So Stefano, where are the areas that IVL really assists EVAR, TEVAR access?
That's a good question. We have 2 main indications if we speak about IVL in EVAR and TEVAR. The main indication is, probably the most common, is to facilitate the endograft delivery. By using IVL, we are increasing the compliance of our vessels. And these allow us to reduce and to avoid the trauma, the rupture, dissection, and decreasing the adjunctive stenting rate. The second indication is the endograft access combined with occlus iliac disease. In this case, we need to deliver our endograft, but we need also to improve the iliac circulation and to improve a limb expansion. And probably a better expanded limb over time could have a lower risk of limb occlusion. Which are the factors to consider? Of course, the length and the size of the lesions, but it's very important to consider the eccentric or concentric calcium and, as we said, the minimal lumen diameter, and in particular, to size the IVL balloon, the reference vessel diameter. These are the main locations at risk. So at the origin of the iliacs, the common iliacs, and at the origin, the external iliacs. And probably in this last case, we have a small caliber and we have the higher rate of rupture and dissection. And again, the length is very important. So we should have focal lesion, or we could have longer lesion, concentric or eccentric. So the planning is very important, is imperative. And we carefully should identify and measure all the lesions on both iliac axes. Why should we use IVL? This is our algorithm that is based on iliac minimum lumen diameter. In case of EVAR and eccentric lesion, we should use IVL in case of lesion equal or below than 5 millimeters. In case of concentric lesion, we should use it in case of lesion equal or below than 6 millimeters. If you are speaking about TEVAR, FEVAR, or BEVAR, we have to deliver a larger bore delivery system. So we need more space. In this case, we should use IVL in case of eccentric lesion equal or below than 6 millimeters, and in case of concentric lesion, equal or below than 7 millimeters. We have many endografts available today, but thanks to IVL, we could not compromise our graft selection by choosing the right endograft for the right patient based on the patient's anatomy. So we can select the low profile or ultra low profile endograft just in case of very narrow width access. This is our experience in Rome, an early experience of 10 patients and 16 iliac axes. So we can clearly see that we had a population unsuitable for endovascular treatment with a minimal lumen diameter less than 4 millimeters. And by reaching and by increasing the luminal gain, we were able to deliver our endografts without any trauma and dissections.